presentation today is paravertebral cervical facet joint blocks and their applications in the practice of prolotherapy. I will try to make my presentation analgesic but not anesthetic.
309.
But what does it say? What does it say there?
It's 309, but
I had 358. 307 was when you started, or 309 approximately. Go back.
Joints. What is the importance of it?
Right there?
People will look
310? Okay.
on the picture which is
309,
being taken from Dr. Hawkins' book.
Okay.
House of
Do you want to hone in on any part of this picture?
pain in the cervical, dorsal as well.
count. You want to count again?
No, I got it written right here. Picture, this is picture number 2, right?
Yeah. This
Actually-
picture number 3, actually.
1, 2, 3. Oh yeah, I know, but I'm counting. Well, that's picture.
On the left-hand side is the work of Dr. Baduk, and you have the handouts of the articles. I'm not sure if Dr. Baduk is familiar with the work of Dr. Hawkins, but you can obviously appreciate it. The overlap is the anatomy of the innervation of the interspinous ligaments and the facet joints. Basically, the structures we are injecting, a majority of the people in the audience are injecting. And this is extremely important for the segmental diagnostic instability, which you are not only curing with this type of injections, but also proving and diagnosing by this type of injections. So for all practical purposes, in the cervical spine, basically, the posterior elements, i.e. everything posterior to the intertransversale membrane, is innervated by the dorsal rami, specifically medial branch. What is the importance of it?
So from
I'm going to go in a little bit now. I'm going to go in. I'm going to come in on it.
what is the importance of it? It's like 309.
But what does it say? What does it say there?
It's 309, but
I had 358. 307 was when you started, or 309 approximately. Go back.
Joints. What is the
309.
importance of it?
Right there?
People will look
310? Okay.
on the picture
309.
which is
309, 310.
being taken from Dr. Hawkins' book. So we have established our anatomical rules. I'm not sure.
No, I got it written right here. Picture, this is picture number 2, right?
Yeah. This
Actually-
picture number 3, actually.
1, 2, 3. Oh yeah, I know, but I'm counting. Well, that's picture
But
3.
it's-
So I'm going to count this. It's actually about 40 seconds. I'll go 45 seconds.
It's 4:51
seconds.
now. It shows over there. Oh, let me go back. 4:47.
I would like to specifically bring your attention to the techniques. Dr. Baduk is advocating 2 types of technique in the injection of the cervical facet joints. Basically, one type of the technique is the posterior lateral approach, which I have demonstrated during the demonstrating section.
Now is where the picture will be.
And the goal of that technique is the fact that you have to inject the lateral aspects of the pillar, vertebral pillar. All right? Basically, there is no transverse processes in the cervical area. The vertebral pillar is the transverse processes on the lateral aspect, as well as on the posterior aspect. The medial branch of the dorsal rami is arising from the just anteriorly to the intertransversalis ligament and crosses around the lateral pillar. And then it gives a branch to one of the joint above and one of the joint below. So from that point, Dr. Badiuk is stating that we have to address, in order to block one facet joint, one of the branches above and one of the branches from below, which is not exactly true. If we're utilizing the same approach and injecting the capsule of the joint, we're basically blocking both branches.
Right here.
So there's no need to deviate the needle upward and downward, which is advocated. For the joint proper, as you can see, he's advocating a 3.5-inch long needle, pure posterior approach with a cephalad direction of the tip of the needle. In my opinion, for those who are not doing this under fluoroscopy, it's a dangerous approach because you might as well end up in the vertebral artery. I wouldn't suggest to put any sclerotic solution in the vertebral artery. It might be slightly uncomfortable. Even a big needle might be slightly uncomfortable in the vertebral artery. It can cause a stroke. So, this is practical points. Now, the blocks we are performing in the office consist of two stages. Initial stage of the block is the injection of the anesthetic solution. At this point, this is the diagnostic procedure. All right? At the second stage of the block, we are disconnecting the syringe containing the anesthetic, pure anesthetic solution, which is usually 0.5 or 1% xylocaine, and connecting the syringe containing the combination of the anesthetic solution, which is usually marcaine, with whatever proliferating solution you desire. In our practice, we are not using anything more than 12.5% glucose or glucose proliferating solution advocated by Hacking or published in Hacking. This is the therapeutic part of it. What's important to realize is every procedure has its indication, contraindication, and how do you go by that. First of all, very careful and thorough physical examination. Secondarily, very thorough 7-view studies of the cervical spine, specifically flexion extension views. On the flexion extension views, you can demonstrate anterior or posterior listhesis, or what we call subluxations. Even the minimal subluxations are important and should be documented because this is the indication for your blocks. And thirdly, as you have seen and I have demonstrated before, we are using video fluoroscopy for that purpose, which is a much better and much advanced method of diagnosing the ligament instability as well as the facet joint capsule relaxation and instability or probably injury or tearing. At one of the latest meetings I have attended in New Orleans, there was a gentleman who is going to publish a study regarding the ultrasonography of the interspinous ligaments. And his statement was that not always our usual findings are corresponding to the real rupture of the interspinous ligaments. So what we can see as far as the instability might be as well a domino effect, which corresponds with the thoughts of a lot of people who are doing this for many years, that the spine itself is an organ. It's not cervical spine, thoracic spine, or lumbar spine. It's an organ. So if there is a ligament rupture, one part of the spine, it will give you the domino effect at multiple levels. But this has also been described in the books of Sirius, you know. So at this point, we have established what we are injecting, what is the purpose of the injections, and why are we doing it. At the initial stage, we like to do the interspinous ligaments. By the time the interspinous ligaments are done, if the patient is not pain-free, then there is indication to proceed with the facet joint blocks. So this is what you document in your protocol. Mr. or Mrs. such and such injection took place to the interspinous ligament at C4 or from C4 to C6 level. 5 minutes later, in spite of the local anesthesia and the prolotherapy solution injected, the pain still remains in the projection of the facet joint at C6, C5, etc. level, whatever you have marked. Providing this fact, there is indication to proceed with the injection of the above-mentioned facet joints. The facet joint was injected one by one, and at the end of the procedure, the patient was pain-free with full restoration of the range of motion in the cervical spine. At this point, you can draw a conclusion of what you have done based on the results of the physical examination, result of fluoroscopic video fluoroscopy study, as well as the results of diagnostic paravertebral blocks and interspinous ligament injections. The patient diagnosis is as follows. Either is relaxation of the ligaments, either this is a rupture of the ligaments, either subluxation secondary to ligament relaxation, and etc. And building your case from there. You can also add that providing the fact that after the injection the patient was pain-free in the distribution, for example, of C6 root, this is the proof that the instability is specific at the level of C5, 6, or 6, 7, whatever we have proven by the injection. And after the injection, the patient was absolutely pain-free. So this is additional diagnostic procedure. In addition, providing the fact that this particular patient, the attempt of manipulation was made prior to the injections, and the patient was difficult to manipulate and was in a lot of pain. 4 facet joint blocks were provided, 2 at the level above and 2 at the level below. After the block, the manipulation was performed to such and such an area. The patient was pain-free. This full restoration of the range of motion was achieved after the injection. So you can, in addition, state that you did a manipulation under anesthesia. Very similar situation could be contributed to the lumbar, dorsal, and dorsal spine, as well as to the sacroiliac joint, iliolumbar ligaments, and you can describe them in a very similar fashion. At this point, I have finished my presentation, which I intend to make very short. I will show you the movie.
Based on the results of previously reviewed plain radiographs, as well as the results of the video fluoroscopy, which we have demonstrated in the beginning of this tape, the patient has a gaping of the facet joints at C4-5 levels bilaterally, as well as hypomobility at C2-3 level on the left side. At this point, I'm going to mark the skin accordingly.
What about this? Right here. This is the one. What about here?
Nothing. Right?
No.
This?
No.
This is not dominant.
No.
Alright. So at this point we have established that the patient has tenderness over 3 facet joints in the cervical area, and these facet joints in particular are going to be addressed during this session. Just 3 facet joints in the cervical area, 1 on the right side and 2 on the left side. As you can see, the patient is being seated astride the chair. In this particular situation, we'll put the pillow under her chest, extending the neck.
Have you heard this before?
Mm-hmm.
Yes. How many other times?
In the neck just once.
Just once?
Yeah.
Did you get relief?
Incredible relief right down my arm. Yeah, I was having problems with the shoulder and the arm. I got incredible relief.
But how long?
Well, pretty much. I mean, I don't get the numbness and the tingling down into my fingers really at all.
Was it primarily your thumb and index finger?
These two, yeah. And it was progressively getting worse. It started with the shoulder.
5,
It was
6.
very stiff. So now I can sleep a lot better too during the night. I mean, it would wake me up depending on how I would move. And any quick movement would upset it. But now it's the tingling and the pain is just it's quite minimal. I was very surprised. I was very happy.
I would like to tell that this is the second session of the addressing the cervical facet joints. During the first session, similar structures or the same structures were addressed, and the patient initially was presenting with the radiculopathy in distribution of the C6 dermatome. She had difficulties to sleep at night with a tingling sensation radiating down the thumb and index finger on the left side. The purpose of addressing the contralateral side facets is first of all their tenderness, and secondarily we would like to establish a adequate tension on the neck bilaterally, thus preventing the subluxation of the facet joints on the contralateral side. So at this point I'm going to be addressing the facet joint at C4-5 level on the right side. This syringe is filled with a 1% of xylocaine. As you can see, the area was marked previously, and at this time I'm going to be just prepping the skin with the alcohol. The approach I'm utilizing is the one described by the Badiuk, which is a posterior lateral approach. I'm rechecking the area of tenderness at this time. Is this the one, Jenna? This is the right? Exactly one, right? Good. So now I'm utilizing a 25 gauge 2-inch long needle. The purpose of utilizing such a long needle is just to be on the safe margin, so as not to introduce the needle as deep as to the cannula and to prevent the complication of breaking the needle inside of the patient. This is the one, right?
What is that you're injecting?
Beg your pardon?
What is that you're injecting?
Xylocaine. At this point, I'm asking the patient if the pain is gone. Is the pain gone?
No, now it is.
Beg your pardon?
Now it is.
All right. So you wait for approximately 35 to 40 seconds until the pain is gone. As you can see now, with the needle left in place, please don't move. I'm disconnecting the syringe with local anesthetic and connecting the syringe containing a combination of Hackett's solution mixed in equal parts with Marcaine, 0.5%. And at this point, approximately 1 cc of this solution is being injected to the facet joint on the right side. I'm trying to withdraw from the syringe so as not to leave the solution in the track of the needle, and fast removing the needle. As you can see, there is almost no bleeding from the injected area. Alright? Now we'll defer our attention to the contralateral side. Again, utilizing the posterior lateral approach with the tip of the needle directed caudally, I'm identifying the painful areas. Is this the one, Janet?
Mm-hmm.
Is this bring you the radiating pain down the left arm?
Mm-hmm.
Yes?
Yes.
Very good. Always keep either thumb or any comfortable finger on the transverse process as your landmark. This is the one, right?
Mm-hmm.
This is the one.
Oh, yes.
This is the pain.
Uh-huh.
Remember that during the introduction of the local anesthetic, you should be able to reproduce the pain because you're distending the facet joint capsule. Is the pain gone?
Mm-hmm. Yeah.
All of the pain is gone?
Yeah.
Very good. At this point, you're disconnecting the syringe containing the local anesthetic. Connecting the syringe with the combination of marking and Hackett solution, and slowly inject approximately 1 cc of that solution into the area. Don't forget to withdraw after injection and remove the needle fast. How is this doing?
Mm-hmm.
This is still painful?
Yeah.
Can you please show us where the pain is? Where's the most of the pain at this point?
Touch, touch.
Alright. Let me palpate the area again. Is this the painful area?
That hurts. Where your thumb is.
Very good. So again, I'm preparing the area with the alcohol. This is the one, Jim?
Mm-hmm.
Alright. I'm on the transverse process at this point, at the tip of it. That's it. This is the pain.
Mm-hmm.
Is the pain gone?
Mm-hmm.
As you can see again, the procedure is bloodless. At this point, I would like the patient to perform 50 exercises in my presence. And let's take a look at her face, how painful she is, or in how much pain she is. Janice, you can pick up your head. Are you dizzy now?
Yes.
And this is a good sign that you have addressed a proper area, because the facet joints do contain the positional receptors. Would you mind please to show us how you do the exercises? You can sit in the chair over there.
This is fine. I don't want to get up. What's amazing is I couldn't do this when I first came. I couldn't move my head to the left without a lot of pain.
I would have to address, though, that as a prerequisite to the injection of the facet joint, I usually require the patient to be driven by their relatives or friends to the office. I don't like them to drive alone after the procedure, because the dizziness might persist for up to 2 hours. Specifically, you have to watch out in the elderly patients. Are you in any pain now in the cervical area?
No, no. I'm serious. I don't
I would
let
like you to
anybody-
smile into the camera.
I don't let anybody take my picture. Unless I'm skiing, because then they can't see me because I wear a mask. I have goggles on, a hat, they don't know who I am.
Do me a favor, smile into the camera for a second. At least this.
No!
You can see
You
that she,
smile into the camera. I'm
you
not
can see that
smiling
she is
into
not
the
in any
camera.
distress. If you are right on the spot, if your diagnosis is right, and I usually tell my patients that if I am right, the proof is in the pudding. You'll be pain-free in 5 minutes after I am done. Right on the spot. And this is how it really works.